Thank you so much for coming today. My name is Beth Newman. I'm with SK Life Science, and it's my pleasure to introduce Dr. David Harris. He is the Medical Director of Neurosurgery and Neuromodulation at Barrow Epilepsy Center, which is in Phoenix, Arizona. So welcome.
Thank you. Welcome. Thanks for having me. So, not a far trip, but I almost didn't make it with all of these flight delays. So I'm happy to be here, happy to talk with you guys. I'm going to try and go quickly so we can have some time at the end, so there can be questions. But if you have a question at any point, just raise your hand. We'll try and make it a little less formal. So, like I was introduced, my clinical expertise is in epilepsy surgery and neuromodulation, so treatments for people with very refractory epilepsies. And that's what I was asked to talk about, treatment pathways for refractory epilepsy. So this is a pretty broad talk, right? This is a big area. It kind of covers everything in epilepsy to some extent. So you're going to probably hear some things that you heard before, but that's okay. You know, if you've heard it a couple of times, maybe it'll stick. So first, you probably all have heard the burden of epilepsy is relatively high. I think when I talk to people who don't have epilepsy or know somebody in epilepsy, they're always surprised at how many people in the world and in their community have epilepsy. So it's about 1% of the world's population has epilepsy for various reasons, and about 10% of people will have a seizure at some point in their life. So this is the University of Florida Stadium. Go Gators! Not a popular sentiment around here. But, you know, if you were at a game and it's 90,000 people at that game, you'd have like 900 people there who have recurrent seizures, and 9,000 people at that game are going to have a seizure at some point in their life. So it is a pretty common thing that people have to deal with. You know, about a third of people who have epilepsy have generalized epilepsy, so seizures that start all over the brain all at once, meaning that most people with epilepsy have focal seizures, starting one place and spreading, and that abnormal electrical activity spreading through the brain is what causes their symptoms. Of people with genetic generalized epilepsy, so it's like 15 to 20% of all epilepsy syndromes. So how do we treat epilepsy? You know, our first line is always going to be medications, right? And this kind of is a graph. You don't have to read all the names here. It's just to give you a sense that this has been the trajectory of treatment for epilepsy over the years, starting even back in the early 1900s, and even going back to bromide. I had a patient in residency who was still on bromide salts, believe it or not. But we certainly have a lot of patients who still take phenobarbital, right? And that's been FDA approved for over 100 years for epilepsy. We have some experience. But you can see that there's been some spates of drug development over the years. But despite all of these really good drug developments, and we have made good improvements in drugs, we really haven't made a huge dent in treating drug-resistant epilepsy. We have better options, better tolerated things, drugs play more nicely with each other, but still the number of people with drug-resistant epilepsy, the percentage of people is still relatively the same. So first we have to define, what do we even mean by drug-resistant epilepsy, right? You know, is it, how many drugs do you have to fail? Like, why do you probably heard if you failed 2 or more drugs, then you have drug-resistant epilepsy. Where does that come from? Why do we say that? So Quan and Brody are the physicians who helped define this for us. And what they, in a single healthcare system, which we don't have it in the U.S., everyone's got their own insurances and everyone's on a kind of a different system, but in a country where you do have that, you can track these numbers really well. And that's what they did. And they showed that in their cohort that patients who try their first drug and fail it, maybe there's going to be about 50% of patients who fail that first drug in monotherapy. And then if you try a second drug added on to that, or in monotherapy by itself, you can get maybe about 63, almost 2/3 of patients seizure-free. But after that, it's really diminishing returns. So if you add on, if you try a third drug in monotherapy, or if you're trying multiple drugs together, you only can eke out maybe another 1 to 2% of all people with epilepsy to become seizure-free. And so it's usually at that point, that's why we say after that second drug, we're calling you drug resistant, because it's a low chance that we're going to be able to make you seizure free with that next drug or with a combination of drugs. Doesn't mean we're not helping, doesn't mean there's not benefit doing that, but maybe we're not going to make you quite seizure free. And then, they did this years ago with some of the older drugs. So we said, we made a bunch of new drugs. You should look at this data again. Basically the same numbers, almost identical. So that was updated about a decade ago. So when we think about patients with epilepsy, with these drug-resistant epilepsies, who's appropriate for epilepsy surgery? It might be as high as anywhere between 10 to 50% of patients, and maybe even more now, given some of our neuromodulatory devices that can be useful for patients with multifocal epilepsy. And we'd still consider that surgery. But unfortunately, even for patients who are potential resective candidates, where you could become seizure-free, could be a curative surgery, maybe only less than 1% of patients are actually referred to an epilepsy surgical center to get that evaluation. When treating really complicated epilepsy, you have to understand what kind of epilepsy does the person have, and we keep changing the names on you guys to really trick you, keep you on your toes. It keeps us on our toes too. So it's just updated this past year. But the keys are, we do break things down into two major groups. It's either we're talking about focal epilepsy, that type of epilepsy where it starts in one place and spreads, and generalized epilepsy, where we think of it as that abnormal electrical activity starting everywhere in the brain all at once. And then, of course, there's unknown, or we haven't classified. Either unknown is we can't tell, even with our good data set, what type somebody has. Unclassified meaning maybe we never seen it and we just don't know what they have. But understanding that difference between focal and generalized, it directs our treatment options, and so it's an important part of this. So can we predict who's going to be refractory to epilepsy? Well, not too well. We're going to assume everyone's going to respond to medications first and hope that that's the case. But there are some factors that might predict whether somebody's going to be a good responder to meds or not so good. So it's for people with generalized epilepsy, it could depend on the subset of epilepsy that they have, whatever type of genetic predisposition is there. But universally, for all comers, people with epilepsy, if they've had a history of complicated febrile seizures as a kid, that might indicate that they're going to be refractory. That early onset of epilepsy with long-standing epilepsy, those patients tend to be a little bit more refractory. If there's multiple seizure types, sometimes that indicates maybe it's a symptomatic generalized epilepsy, or maybe it's multifocal epilepsy, and those tend to be a bit more refractory. If a person's ever had status epilepticus, that history means that they're probably going to be more refractory in the future. If they have concomitant developmental disability, learning delay, that indicates maybe there's more of a global problem in the brain, and those patients also tend to be a little bit more refractory. And if there's any other sorts of comorbid psychopathologies, they tend to not do as well with seizure medications. So depression is so common that it's not so much of a... So the question was, does depression and autism spectrum disorder, do those two things predict whether somebody's going to be refractory? Now, depression and anxiety, probably not so much. It's so common. We see it so frequently in all of our epilepsy patients, maybe as frequently as 50% of particularly our refractory epilepsy population has clinical depression or anxiety. So that needs to be treated, and it can impact somebody's care with epilepsy, but it's not necessarily a predictor that they're not going to be good responders to the meds. Autism spectrum disorder is a little different. People with ASD are more likely to have epilepsy, but just having that diagnosis and being a little neuroatypical doesn't necessarily mean you're going to be refractory. It depends on if your ASD syndrome comes with the intellectual delay that it sometimes can. So it depends on the severity of the diagnosis. And if there is intellectual disability, then you are more likely to be refractory. So there's some genetic epilepsy subsyndromes that have a known pretty good prognosis. And the classics are childhood absence epilepsy, juvenile absence epilepsy and juvenile myoclonic epilepsy. But even in this cohort of patients, a significant number of them are going to prove to be medically refractory. And so we just need to keep that in mind. And so we talked about the intellectual disability. There's also certain subsyndromes of epilepsy that are known to be very refractory, and these patients have a lot of comorbidity associated with their seizures. So Lennox-Gastaut syndrome and severe myoclonic epilepsy in infancy, or Dravet syndrome, which is a specific genetic type of epilepsy, mostly associated about 80% with SCN1A mutations. And then there's a host of other, what we call epileptic encephalopathies, where patients have an underlying brain disorder that comes with epilepsy, but it's driving the epilepsy, and not so much that the epilepsy is driving it, although there's probably two-way feedback there. There's other genetic conditions such as inborn errors of metabolism that can be associated with seizures. And then there's GLUT1 deficiency syndrome, which is a genetic disorder that comes with movement disorders in epilepsy, but is a little different. We'll talk about it in a bit. So why do we care? Right? Why do we care that we're having all these seizures? Question. Sure. Is that better? All right. I'll just stand a little closer. Is that good? All right. So obviously, just from the impact of epilepsy on your life, that is, it can be very impactful. Just it's disrupting your day. You can have injuries. There's these sorts of things, but we know that there are other long-term complications of refractory seizures, right? So certainly, if you're having refractory seizures in infancy, in really important stages of development, that can impact you a lot. There can be regressions of skills that are gained early on, can be lost, and then people are behind and they get some delays. And the idea here is that seizures, they're a pathological way our neurons are communicating with each other. And so when they're communicating pathologically, we're changing the way these neuronal pathways are connected, and that can really impact patients' cognitions early on. And as kids get older and we're adults, this is the adult room, we know that refractory seizures impact lives in other ways. Our social relationships are significantly impacted by epilepsy. And so one study shows that about a third of patients with drug-resistant epilepsy describe these disrupted social relationships with 28% with their spouse or partners, about a quarter of people with their children. Patients' sexual health is impacted by this. They're less likely to get married and less likely to have children. There's also, of course, physical effects of both seizures and the drugs we use to treat seizures. So things like decreased bone density, other endocrine disorders, elevated cholesterol and lipids we have to be a little conscientious about sometimes, weight loss or weight gain. And then, of course, injuries and accidents, right? Broken bones. We just had a talk on TBI in here. So TBIs from seizures themselves are a concern as well. And seizures can also impact executive function or frontal lobe function, which can cause essentially ADHD, and that needs to be addressed as well. And then, of course, there's the more certainly severe complications, things like death from accidents, drowning. Somebody asked in the last session, what are your what makes you nervous as a clinician? What makes me nervous as an adult epileptologist in my clinic is drowning. It's very dangerous. Even, a couple inches of standing water could be deadly if you were to fall in the prone position after a seizure. Aspiration, yes.
What does aspiration mean?
Aspiration is having something go down the wrong tube into the lungs. Yeah, so that could be your own saliva, managing your secretions after. Some people have increased secretions from their seizure, and so that could aspirate down the wrong tube. I've had patients who have seizures while they're eating, and they could aspirate in that condition as well. And certainly status epilepticus can be dangerous to the brain by itself and can also lead to severe complications. And then, of course, the big elephant in the room is sudden unexpected death in epilepsy. Yes, sir?
I have a question. How do you pinpoint the specific location in the brain where the
It's a good question. So the question is how do we pinpoint the area in the brain where the seizures are coming from? And I'm going to talk about that in just a little bit. But there's a lot of studies you want to do that might be necessary to get to that point. And for people with focal epilepsy, that can be a really important, that is the name of the game when we're thinking about something like epilepsy surgery. But for generalized, so I'm going to talk a little bit about generalized epilepsy, then we'll get to focal epilepsy a little bit. So there's obviously medical, surgical approaches, surgical being resection in this case, but there's also neuromodulatory devices as well that can be helpful for generalized epilepsy syndromes. When it comes to medications, I'll go through this a little quickly, but we want to avoid medications that are more specific for focal epilepsies. This includes some of the voltage-gated sodium blockers, and also certain GABAergic drugs like gabapentin and pregabalin are some of the ones I worry about the most. And if you're seeing an epileptologist, they're going to know this. But I've even seen patients come into my clinic who have a generalized epilepsy syndrome coming from another neurologist, and they're on one of these meds, and it's almost mind-boggling. I'm like, no, get off that med. So it does happen. Just be aware that some medications, particularly for generalized epilepsies, can be exacerbating. And then there's a number of medications that are approved for genetic generalized epilepsy, and we consider these broad spectrum because basically all the drugs work for focal epilepsy, and it just kind of works out that way. But we have to be a little bit careful about the generalized epilepsies. So these ones here, valproate, lamotrigine, levetiracetam, topiramate, and perampanel, which we'll talk about a little bit, are all approved for generalized seizures. Also, kind of in this category is Lennox-Gastaut syndrome, which is not specifically a genetic generalized epilepsy. It's a more whole brain disorder that manifests with generalized seizures as well, but they can have focal seizures too. And there's a number of drugs that have been approved for whether it's LGS or Dravet syndrome, and maybe they also have good efficacy for the generalized seizures seen in people with genetic generalized epilepsy. And then there are drugs that are maybe more specific for certain conditions. So, for example, tuberous sclerosis complex, there's a couple of drugs that are known to work very well for that. So working with a specialist, if you have any of those specific conditions, is really important. Now, perampanel, I'm going to talk a little bit about quote-unquote newer therapies, although perampanel is not newish, I guess, at this point. Approved about 10 years ago, actually, for the treatment of epilepsy. But I like it because they named it easy for me to remember how it works. So they put AMPA in the name, and it works on AMPA receptors in the brain. And what that does is it essentially blocks the signaling from one neuron, so one hyperexcitable neuron to the next, dampening down that hyperexcitability. And in generalized epilepsy patients, it was shown to make a significant number of people seizure-free over the course of this study. 31% actually developed seizure freedom during the study compared to 12% in the placebo group. And it doesn't just work for the generalized tonic-clonic seizures, which is important. Some drugs we have kind of work really well for the generalized tonic-clonic seizures, which is the most important type that we want to control. But then what about the myoclonic seizures or the absence seizures? And it seems like perampanel works well for all three. You do have to be a little conscientious, though. There's a black box warning on perampanel. It can cause aggression, hostility, irritability, anger, and homicidal ideation. Now, I've never seen any patients have that, but I have seen some that aggression and irritability, so you just have to be aware of that. Like a lot of our drugs, it can make patients a little dizzy. It can also cause some GI distress. I had a patient who did really, really well on perampanel. Essentially, it controlled her epilepsy. She was a nurse in Michigan, but she had severe constipation. And so the limiting factor for us titrating her medication was severe constipation, and we just had to manage that because she felt like she was doing so well on it, she didn't want to try something else. And then also, like a lot of our medications, it can make you tired. That's pretty common with a lot of our medications, either by themselves or even more commonly when it's paired in combinations with each other. I'm going to bring up some also some not so newer options like lacosamide, which is a sodium channel drug, but works on a different receptor than other sodium channel drugs that work on that voltage gated sodium channel, which I told you is not good for generalized epilepsy, but it turns out lacosamide can be, and there was a 2016 open label study looking at folks with generalized epilepsy that showed that it is effective. Brivaracetam is a cousin of levetiracetam, so while it's not approved for generalized epilepsy, the mechanism of action is very similar. In fact, it's working at the same receptor, so it should work, and there has been data to support that as well. Now, clobazam is, probably a lot of you have heard of this medication. Onfi is the other name for it. It's like our rescue medications, and benzodiazepines work for seemingly all types of epilepsy. But clobazam is different than the other benzodiazepines. It's a long-acting drug, so it's not in and out of your system very quickly. And because of that, maybe because it's actually molecularly a little different than the other benzodiazepines, you don't get that same effect where over time, over years, you need more of it to get the same effect. That's that tachyphylaxis. So we like it for long-term use of epilepsy, and it's another way to control, especially if we're adding meds together to treat people's epilepsy. Of course, the biggest downside is going to be the drowsiness. So I usually prescribe it at night for that case, and it can also cause constipation. Also slows down the gut a bit. CBD, also one that's probably you guys have heard quite a lot about, approved for the treatment of Lennox-Gastaut syndrome and Dravet syndrome. However, probably does have some efficacy in other epilepsies as well. A lot of drugs get approved for LGS and Dravet because it's easier to do those studies. Those patients have a lot of seizures, and so the time you have to do that study is less, so it's a lot cheaper. But it doesn't mean they don't work for other epilepsies. Cannabidiol is the constituent of marijuana just under tetrahydrocannabinol. THC, 9-delta THC, is that psychoactive component of marijuana. CBD is non-psychoactive, so it's not going to make you feel high or knock you out like the THC effect will. Also can cause some GI issues. That's probably the biggest thing with this one because it's an oil, and the oil causes a little GI distress. How it works is not really clear. We know that there are what are called endogenous cannabinoid receptors in the brain, so there is a role for the signaling pathway, but we don't actually know how it's making a difference in epilepsy specifically. The other thing it does is if you're on clobazam, which a lot of patients with epilepsy are, it actually it reduces the metabolism of the major metabolite, which is an active metabolite, meaning it's working to treat your epilepsy. So it's increasing those serum levels, which probably also impacts its efficacy. It's working through that way as well. Now, there's pharmaceutical grade cannabidiol. There's an FDA-approved drug called Epidiolex. A lot of my patients, especially now that even not just medical marijuana, but recreational marijuana is much easier to get. I live in Phoenix, so Arizona, recreational marijuana is legal. I used to live in Michigan, where recreational marijuana is legal. So a lot of my patients are like, well, I'll just get CBD. I don't want to deal with the insurance company. I'll just go to the dispensary and get some. That's probably not the smartest thing to do because even if you're getting what you think is maybe a pure CBD, it's going to be cost prohibitive. The doses you need to get are much higher than you're probably going to be able to get at a dispensary, so it's going to be cost prohibitive, I think, to do that. And then newer on the market is fenfluramine. Maybe if for the older people here, you remember fen-phen from the 70s, the weight loss drug. This is one of the phens. But it turns out, so there were some issues with fen-phen in the 70s. It caused some people to have sudden death because of heart valve stenosis. Now, it was probably the combination that was really exacerbating that, but it turns out that fenfluramine can be very useful for treating people with seizures, and maybe that's, and it's also nice as a new drug because it has a different mechanism of action. It's what's called a serotonin agonist, and we don't really have any other drugs that work that way and also treat seizures. So that heart valve stenosis, and which can lead to pulmonary hypertension, is something you have to be very careful about. But the company that produced this, we really haven't seen any significant stenosis with the doses we use for treatment of epilepsy and just by itself. So it is a consideration, but it does require you to get echocardiograms every 6 months when you're on the drug to make sure you're not developing anything like that. But anecdotally, I've had some patients, one patient on this, and they've done well. It's approved for Lennox-Gastaut syndrome and Dravet syndrome, but like the last speaker said, a lot of these drugs get approved for one thing, and then we start to see, does it work for other things? And they kind of develop a new life there. This one so far hasn't, mostly because of the limitations with the echocardiograms. And then there's cenobamate, which was approved in 2019, and has maybe the remarkable quality that in patients with drug-resistant epilepsy, where we say, yeah, the next drug's probably not going to be the one that does it. This one actually has a good track record of giving people long periods of seizure freedom. So in the initial trials, there were two, it was 21 and 28% were seizure-free. And then in the real-world data, maybe even like almost a third of patients had prolonged periods of seizure freedom.
Oh,
Yes?
GGE stand for?
That's genetic generalized epilepsy, is GGE. Maybe one of the reasons it's good is because it has at least 2 known mechanisms of action. And so it's almost like in one medication, you're getting that rational polypharmacy of treating the epilepsy in 2 different ways. It's got some drawbacks, though. It's a very slow titration. It takes a few months usually to get up to a therapeutic dose. Otherwise, you run the risk of developing some severe hypersensitivity reactions. And maybe because of those multiple mechanisms of action, it doesn't really play well with others. There's a lot of drug-drug interactions, both in metabolism effects, but also in the side effect profile because of those overlapping mechanisms. Again, most of the side effects I see with patients is it either causes the drowsiness, significant drowsiness, or significant dizziness, double vision, blurry vision, which is that sodium channel effect. And so what I tell patients is if they're already on a couple medications, maybe 3 medications, I tell them if we're going to start this one, we're probably coming off at least one of those other medications, kind of to make room for it. Now, diets can have a role in drug-resistant epilepsy as well. Probably the one that's the most known and best studied is the ketogenic diet. I'm not going to talk too much about that, other than you just need to know it's a high-fat, low-carbohydrate diet that leads to development of ketones in the system. And ketones are a source of energy for our brain. So the primary source of energy for our brain is glucose, sugar. Ketones are a more complex molecule, but our brain can also use that as an energy source. And so using ketones instead of glucose causes some changes in the brain that does seem to be helpful for epilepsy. But this is usually like something you're going to do after you've already tried a few medications and things that we know are going to work a little bit better. And it's not by itself. This is always in addition as what we call an adjunctive agent for treatment of refractory epilepsy. Like I said, we don't really know how it works, but there's some hand-waving stuff that goes around trying to understand how it might work. But it is the drug of choice for specific genetic conditions, particularly GLUT1 deficiency. And so as a clinician, you always want to keep that in mind that if there is a underlying genetic etiology for somebody's epilepsy, it might direct our treatment in a specific way. It's been studied in status epilepticus, as almost all of our drugs have, and usually it's something you would tack on after you've already tried a few different things in somebody who's super refractory with their status epilepticus, but can be helpful in those cases. There are some difficulties with some short-term and long-term side effects. I don't usually recommend it for my adult patients. It's very difficult. You have to stay in ketosis the entire time or it loses its effect. It's hard to do. It's hard to maintain that ketosis. There's other things you have to be conscientious about, like liver function, that sort of thing. And maybe there's limited data that the modified Atkins diet, which is a much easier diet to be on, frankly, and more tasty, is maybe just as good in adults. But regardless, I would recommend doing this under the guidance of a registered dietitian so that they can be following the labs they need to follow and making sure it's being done in an effective and safe way. For generalized epilepsies, particularly patients with atonic seizures where they just fall suddenly and it can be very dangerous, there are some surgical options for that. Now, it's not like the single point with generalized epilepsy. People with generalized epilepsy starting all over the brain all at once. So it's not like a single place you can go. But if you're trying to avoid that loss of tone that causes falls, you can disrupt the connection between the two hemispheres of the brain. And that's called a corpus callosotomy. That can be done in two ways. One, surgically, open, where the surgeon goes in and actually cuts the corpus callosum here. And so there's less communication between the two. Or there's now what's called lit therapy, laser interstitial thermal ablation therapy. And that's where a probe goes and the tip of the probe heats up and damages that tissue so that the two hemispheres can't are no longer talking. So we'll jump, before we talk about neuromodulation, I'm looking at my time, we'll talk a little bit about focal epilepsy. And so again, to the question of if you have focal epilepsy and you've proven to be medically refractory, what are the steps then to go and then figure out where it's coming from and is surgery appropriate and what kind of surgery? So one is first defining what refractoriness is, and that's not a clear-cut thing, and it might be different for each individual. So, in my clinic, it's an open conversation. For someone who's having 2 seizures a year, but they can't drive because of that, that's still impacting their life significantly. If they're having many seizures, but the seizures aren't impacting them that much, maybe we're not going to pursue something like epilepsy surgery. If they're having even a few tonic-clonic seizures a year, that's increased risk of SUDEP, and then it's a more urgent situation. We need to figure out if there is an epileptogenic onset zone that is resectable for doing resection, and there's a lot of different testing we do to try and figure that out. But there's other considerations as well. If we're thinking about resecting a part of somebody's brain, that can have significant impacts on people's psychology. And so is somebody psychologically stable before going down that process to be able to do that? Do they have the social backing, the setup to be able to recover and handle a surgery? What's their expectations like? What's their support system? And then, are they willing? Somebody might come into my clinic and I think that they should be an epilepsy surgery candidate, but that doesn't necessarily mean that they want to be an epilepsy surgery candidate. For some people, doing a brain surgery is not something they'd ever consider doing, right? For lots of reasons. It could be cultural, religious, or just personal preference. Or maybe they've had a bad experience with surgery before and they don't want to go through that again. And that's completely understandable, and that's a conversation you have with your doctor about, all right, well, what are the right things for me? Yes?
This was back in the 80s, I was 23, and they said that my surgery was perfect because it's in a TLE.
I was going to get maybe just speak up.
In the 80s, I had a temporal lobectomy, right?
Mm-hmm.
And they wanted to, I was at UCSD, and they said it's perfect, it's just my place, that we can go in there and get it. But I was 23, and so I was very, at that age, I don't know if I could say vain or something, but the main reason why I wouldn't have it is I didn't want to cut my hair. So I'm like, no, my hair at this time was only down here, but 24 years old. So I got a second opinion, and he said, I cut my hair down.
Yeah.
So I said, yeah, to that. That's the only reason why.
I completely appreciate that. Having worked with multiple neurosurgeons, the techniques can be very different, and how you come out of that surgery can look very different. So where your scar is, how big the scar is, whether they shave your head. There you go.
He shaved from here down, and my hair at that time was on here, so I just flipped it over and
There you go. So there may be many reasons that you might be hesitant to do a surgery, and vanity is a fair one. All right, so let's talk about the non-invasive testing we do for focal epilepsy to determine if you're a surgical candidate. So that first one's going to be the epilepsy monitoring unit. So maybe some of you have been in an epilepsy monitoring unit before. This is where we bring you in and we make sure we understand what's going on with your seizures. That's the first step. And if we're thinking about resective surgery, hopefully we're thinking about a single focus where your seizures are coming from. And so one question that sometimes comes up is, well, how many seizures do I need to have for us to be pretty confident it's just a single focus? And that kind of depends. Maybe it's 3, maybe it's 7, maybe it's 9. It depends on what your pretest probability is going into that test. So if you think very likely that based on all the evidence I have, there's a single symptomatology with the seizures, the routine EEGs didn't show any areas outside of the area I think the seizures are coming from, then you're going to be very confident and you need to see fewer seizures. But if there's a lot of questions about maybe there's multifocal or maybe there's different types of seizures, you're going to want to capture more to make sure you're dealing with a single type of event. When you're in the epilepsy monitoring unit, how fast we take away your meds there's no standard, there's no guideline. Fast might be doing about 1/3 of your medications a day. Slow would be less than that, between 10 and 30%. And there's pluses and minuses to both. One, the faster you go, the quicker the chances are we're going to capture your seizures. But maybe we capture bigger seizures, or maybe we get clusters of seizures that are a little bit more dangerous. But if we go slow, maybe we don't capture what we want to, and we don't get. You come to the epilepsy monitoring unit for a week or sometimes 2 weeks, and we don't get the information we need. There's a lot of different imaging techniques out there that can be useful. Certainly the first one is a really good quality MRI. And not any MRI. People think, oh, I got a brain MRI, that's sufficient. That may not be the case. We want first of all, a 3T is the standard these days. That's a 3 Tesla. That's the strength of the magnet. Not every sort of outpatient imaging center has that. And we also want it done with an epilepsy protocol. What does that mean? It means we're doing high-resolution cuts through the areas, particularly the temporal lobes and maybe the frontal lobes, where it's a high likelihood we're going to see an abnormality in somebody with focal epilepsy. And there may be other sequences as well that at maybe a level 4 epilepsy center they're going to do to try and figure that out. There's also, the MRI shows you the structure of the brain, but there's some tests to look at the function of the brain, and one of those might be a PET, which looks at how your brain utilizes glucose. That can give us more data, particularly if your MRI is negative, doesn't have a lesion. Sometimes a functional lesion can be shown. SysCom is another type of test where we inject a radio tracer during a seizure and follow the blood flow, and areas that are seizing are very metabolically active, so there's a lot of blood flow there, and that can help us pinpoint where the seizures are coming from. And there's other types of tests too. So for example, there's the magnetoencephalogram. This is different from an EEG because it shows the magnetic activity of the neuronal activity. So it's looking instead of the electrical activity like an EEG does. And for areas of the brain that are sometimes invisible to scalp EEG, the magnetoencephalogram can be very helpful. This is a picture of our PhD, who's the technical director of our Meg Lab, and this is our beautiful new Meg at the Barrow Neurological Institute in Phoenix. They all look so happy in there. I don't know. Exactly. Now, the high-density EEG is kind of similar to this, except it's also looking at source analysis, where we're taking these signals and pinpointing in 3D space where they're coming from, but it's using EEG technology, which has been around for forever, which you're all familiar with, but with a lot more electrodes. So instead of just doing the typical channels on the head, it's a whole net of electrodes that come down a lot further, and we're able to better model those signals in 3D space and pinpoint in your brain where they're coming from. So we have both of those at Barrow. Not everyone, these are relatively rarer types of technologies, even for advanced level 4 centers. Other tests that you'll probably get, or you may get during this process, one is a WADA test named after June Wada. That doesn't stand for anything. And that's a test where we almost simulate what it would be like if you were to get a surgery where we put half of your brain to sleep and make sure that your language and your memory are still functional. And then, of course, neuropsych testing is a pivotal part of all of this as well. That helps us understand objectively what cognitive domains might be affected by your epilepsy, and correlating that with all the other data is really important to make sure that, one, everything's aligning and that we're not missing anything. We always want to think about a person's psychology. Seizures are important. I'm an epileptologist. I think seizures are very important. But certainly, the brain is home to all of our processes: cognitive processing, emotional processing, and we want to make sure that people do well after a surgery, that they're not, we made them seizure-free, but now their life is terrible. That's not our goal. And so we know that patients with temporal lobe epilepsy, which is the most common type of focal epilepsy, are going to be at higher risk for things like depression and anxiety after surgery. And we just need to be aware of that and be very on guard about that so that we can identify it early and treat it if we need to. And patients need to be aware of that going in, that there are these potential consequences. Yes, ma'am?
So TL means temporal lobe. What about ETL?
That's extratemporal lobe, just outside of the temporal lobe. Yeah. So as compared to, say, you have a frontal lobe epilepsy or parietal or even occipital. And then the timing to look for this is usually actually in the very early postoperative period. So usually this is a transient phenomenon if you're getting a worsening. And then it tends to get better, but you still need to be aware of it and treat it, because it can last for months. There are, of course, social barriers to getting a surgery. These could be socioeconomic. I couldn't get a ride to go to the test I needed as part of my surgical workup. There are cultural barriers potentially. Patients who, now I'm living in Phoenix. We have a lot of patients who live on reservation, and there are maybe some cultural taboos about doing a surgery that might be curative for somebody's epilepsy. So that goes with racial. There's certainly access issues also for my patients on reservations. Being able to even communicate sometimes is difficult. Sometimes there's not good Wi-Fi, so they can't access us through the portal system. So we just need to be aware of that and come up with strategies to get around that. And of course, stigma is a big one. So the stigma of having your head shaved for a surgery is one that, particularly for younger people, could be really important and needs to be addressed. There are post-surgical barriers. So, how well somebody does is dependent on how well their expectations match with reality. And so we need to make sure that, people aren't going in thinking, well, I'm going to suddenly stop all of my meds and I'm going to be, my life is going to be fixed completely. I'm going to go back to work, even though I haven't been working for 10 years. No, it's a process. Even if we make you seizure-free, there's other things that have to be addressed. And then I would say, just before we move on to neuromodulation, having a social worker evaluation for us is a really important part of this whole thing. It's somebody who can do some of this evaluation ahead of time, things we don't always talk about in the clinic because we end up using all our time talking about other things, but these are still important. I think having a social worker to do that pre-surgical evaluation and then a post-surgical follow-up is key. So now we'll talk a little bit about neuromodulation in the little time I have left. This is, really where the world is at right now, and how do we manage people with very refractory epilepsy if they're not like a resective surgical candidate. And so this guy, Dr. Corning, he had the idea of doing vagal nerve stimulation even as far back as the late 1800s. This was a completely different idea than what we currently do for vagal nerve stimulation to treat epilepsy. He had this sort of almost collar thing. He would almost like choking off the blood flow to the brain. That was the whole idea. We were going to use the vagal nerve to slow down the heart. We're going to deprive the brain of blood. It's got too much blood. And that's going to stop people's seizures. And it turns out, actually, if you deprive the brain of blood, you might stop their seizures. But there's some consequences to that a little bit. Our modern system doesn't do that. We only stimulate the vagus nerve on one side. It's two sides. We're only going to do one side. Doesn't tend to affect heart rate at all. And the whole basis was that back in the 80s, a researcher at Penn had this idea that maybe, we know the vagus nerve goes to the lungs, it goes to the gut, it kind of goes to a lot of these organs in the body, but it must have feedback going back to the brain, so we can affect brain processes by stimulating the nerve higher up. And that's what he did. He did a lot of animal studies, and then he developed a product, and then he basically started selling his product because there was not much else out at the time. And eventually they did the studies that showed that it actually is effective, and it got approval all the way back in '97. So we've had this now for almost 30 years. And it's implanted now. This number is more like 120,000 patients worldwide. And it's been shown, while approved for focal epilepsy and ultimately also for depression, although that data is weaker, there's good evidence to suggest it's also useful in other types of epilepsy, including genetic generalized epilepsy. In Europe, actually, it's approved for genetic generalized epilepsy. Here in the US, it doesn't have that FDA approval. And also in our epileptic encephalopathies like Lennox-Gastaut syndrome and Dravet syndrome. But it takes time to work. Just keep that in mind with any of these devices, but maybe particularly with VNS. The number of patients who have a 50% reduction or better, is maybe only 40% in that first year, but as you get out year by year, the number of people who've had a pretty significant reduction in their seizures gets better. And in fact, all of the devices show a similar pattern. It's also been shown to have utility in atonic seizures, which is otherwise, we were talking about corpus callosotomy or surgery, and maybe some medications like perampanel, but there's not a lot that have been shown to have good effect in atonic seizures. And now the modern devices also have a responsive component to them where they're responding to changes in heart rate, usually elevations in heart rate related to seizures, so giving extra stimulation to abort seizures in real time. Maybe a little bit more modern than VNS is deep brain stimulation, and this is a technique that was developed for movement disorders and then adapted for epilepsy, particularly focal epilepsy. The initial trial was Sante trial in 2010, although it took them 8 years to get a FDA approval. It stands for the stimulation of the anterior nucleus of the thalamus, so that takes me to a quick little sidebar here. The thalamus is this deep structure deep in the brain. That's why we call it deep brain stimulation. And it's a hub of connectivity in the brain. So this is a picture from a recent article showing you some of the different nuclei of the thalamus and their projections to different parts of the brain. So as you can imagine, the back of the thalamus projects to the back of the brain. Go back. There we go. The front of the thalamus projects to the front of the brain and to the temporal lobe. In the middle part of the thalamus, some of the middle nuclei project more to the middle parts, particularly the areas of what's called the homunculus, the somatosensory cortex. Yeah?
So what does SANT stand for again?
That's the name of the trial. Sante was the name of the trial. They eventually did get FDA approval for adults with intractable focal seizures, but as you can imagine from that diagram, it worked best for patients who had seizures coming from the temporal lobe and the frontal lobe, which are where the major projections from the anterior nucleus of the thalamus go. And it is ultimately the majority of our patients with focal epilepsy. However, we do have patients with seizures coming from outside of that area, the area between the frontal lobe and the temporal lobe called the insula, the parietal lobe, the occipital lobe, and those patients did not do as well with this type of stimulation, or at least this location of stimulation. This led to a later trial called the Estelle trial in 2022, which was looking at the centromedian, so a central nucleus of the thalamus, which has more projections bilaterally to the central areas, specifically looking at Lennox-Gastaut syndrome patients. Now, this is a very specific population, so it's hard to take this data and then apply it to people with other types of epilepsy. However, we think that that's also a location that would be good for generalized epilepsy syndromes, and there's the results of a neuromodulation study probably being presented in a few weeks looking at just that. This was a small study, and what we learned from that is that it does matter where you're stimulating, how you stimulate. There's different connectivity, there are different pathways that are nearby, and so you have to go slower in this area, or else people don't like it, they don't feel good. Responsive neurostimulation is a different neuromodulatory device, but very useful and can give us a lot of data that maybe some of the other devices can't give us. So this is essentially the device, and so instead of an IPG, so that pulse generator that's getting implanted underneath the skin and maybe the muscle in the chest, this gets implanted into the skull itself and is connected to two electrodes, either a strip electrode that goes along the surface of the brain or a depth electrode that goes deep into the brain, or two of each of those types. But only two can be connected at the time, which has to do with its approval for 2 or fewer epileptogenic foci. So if you don't, even if you have more than one, you have 2, you can still use this device. It's approved for that to treat your epilepsy. But there are maybe more modern theories about how to use this device in simulation that could affect bigger regions. But that's for a different talk. And not only is it therapeutic for treating, yes?
So are the probes going to specific spots in the brain?
So good question. So the question is, are they going to a specific spot? Are they going, or is it more tailored to the individual? So unlike the DBS system, which its approval was based on sort of a generic spot to stimulate to treat all comers, this device is specific. You need to know where the person's seizures are coming from. And that usually involves the second phase of a surgical workup, which is usually an intracranial study, where we actually place electrodes into the brain to better specify where those seizures are coming from. Good question. This device can be diagnostic as well. So unlike the other devices, this one records brain activity. It's the only device we have that's responsive to the cortical activity of the brain itself. And so when we train it to recognize a seizure, you can see that it does give stimulation, but it also can tell us where that seizure is coming from because we have 2 electrodes. So for people who have a question of bitemporal epilepsy, for example, we can have an electrode on the left, which is these top 2 channels, one on the right, that's these bottom 2, and we can count how many seizures come from one side versus the other. It's better than a 1 week or 2 week stay in the EMU, which can only give us a snapshot in time. This is a black box in the brain that can give us this data over the course of a year or years. And if somebody's seizures are 80% from one side, they may be eligible for a curative surgery. And like with the other devices, it gets better over time. So take-home recommendations, talk to your provider about treatment options. There's a lot out there. I would recommend, if you have refractory epilepsy, to consider a level 4 epilepsy center. The NAAC is the accrediting body. A level 4 center, while you can get good treatment at other centers as well, the level 4 center is going to have all the options or more options for your treatment. And if you're refractory, that's worthwhile. And there's evidence in the literature to suggest that people with refractory epilepsy do better if they're seeing a neurologist rather than a GP, better if they're seeing an epileptologist rather than a neurologist, and maybe even better if they're at a level 4 center. Remember your epilepsy hygiene. So we can do all these fancy things, we can treat your epilepsy, but it still comes down to the basics. You want to be doing everything you can to be treating your epilepsy, which is good night's rest, regular sleep, undisrupted sleep, restful sleep. So if you have obstructive sleep apnea, treating that. If you have insomnia, treating that, for example. Having a good routine at bedtime. Not missing your medications, and this is very difficult sometimes, but there's now a lot of apps. There's even these different devices that can be used to make sure you're taking your medications. The most common cause of breakthrough seizures we see in the emergency room is people forgot their meds. And maybe you don't remember forgetting your meds, but that's part of epilepsy, right? Sometimes your memory isn't that great, and so you need all of these different strategies to make sure that you're 100% taking your medications on time and not missing doses. And then stress. Stress is a big one too, and we need to do as much as we can to reduce stress, which is hard in our current environment, pretty much hard all the time, but building it into your day, saying, I'm going to take 10, 20 minutes and do something that is stress reducing, whether that's playing video games or reading a book or for some people it's mindfulness meditation, which I do recommend for some patients. But anything it is good. And exercise. What's good for the body is good for the brain. And I'll leave you with that. I do want to highlight, this is our team of nurses, epilepsy nurses and technologists who really make what we do possible at Barrow. And this is at the ribbon cutting for our new epilepsy monitoring unit. So it's a nice picture. Thanks.